Hello everyone, welcome to the February 2024 meeting of the Implementation Science Interest Group, where Dr. Georgia Fisher will be presenting on using the theoretical domains framework in healthcare research. Just a note that this introduction recording was done after the fact, as there were a few technical issues on the day. We have edited the technical issues out of the recording, but if the audio jumps around a bit, that is why. Hopefully it should be fairly consistent though through Georgia's presentation. So just to fill in an acknowledgement of country for the introduction, so I acknowledge the traditional custodians of the Macquarie University land, the Wadawurrung clan of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since the Dreamtime. We pay our respects to elders past, present and future. This next slide is just an overview of the committee and where you can contact us. And then over to Georgia Fisher's presentation. So Dr. Fisher is a postdoctoral fellow at the Australian Institute of Health Innovation, and we'll be presenting today on facilitating practice change using the theoretical domains framework and COMB model in healthcare research.
It really piqued my interest because I found that as a clinician, it was really hard to assess that kind of effect. And I tried to find the best research evidence that I could for the condition, and I really wasn't able to use it in practice because lots of different things were getting in the way. So I started off doing a PhD at the University of Technology, Sydney, which specifically aimed to look at both proprioception and unilateral neglect after a stroke. And the main focus of the thesis was to figure out how we could assess it better in clinical practice in ways that were suitable to clinicians and that suited the ways that they practiced. After that PhD, I took a postdoctoral fellowship at Neuroscience Research Australia in the lab of Simon Gandevia, looking at proprioception and motor impairment. And this was a far more lab-based postdoc, which I really enjoyed. It gave me a really good grounding in bench research. But I found that I really wanted to get back to my clinical roots. So I've started a postdoc here at AIHI. I'm currently looking at learning health systems, but I have a broader focus on implementation science in my research.
So today, as I said, I'll be talking about the theoretical domains framework, which is a framework that I've used quite a bit in my own research. I came to working with it because in my PhD, I was trying to find a way to figure out what were the barriers and enablers that kind of got in the way of assessing spatial neglect in clinical practice. And because I was looking at it at the level of the clinician, I really liked the way that this framework kind of spoke to individual determinants of behaviour, but at the same time taking into the context that clinicians were working in. So the aim today will be to give you an overview of the framework and also map it to some practical ways that we can use it in our research. So the theoretical domains framework was developed to identify influences on behaviour, particularly for health professional behaviour. It brought together quite a lot of experience and knowledge in its development, in that it was developed by a lot of psychological theorists, health service researchers and health psychologists. And the good job that it did was combining a lot of theories of behaviour into one framework that we can kind of use to analyse the way that behaviour is driven. So there was 33 theories of behaviour that were brought together, and from these 128 theoretical constructs were identified, which is still a bit much for us to use in our day-to-day research. So they clustered them into 14 domains, and then these domains underwent quite an extensive validation via discriminant content validation and a fuzzy cluster analysis, which is just two more fancy ways of checking that categories are in fact what they seem to be. Okay, so the TDF has been used in countless research studies, both in healthcare and also in other fields, so it's broadening out. And a search of the theoretical domains framework in PubMed yields 1,386 results. But as you can see at the graph there, the number is really growing exponentially each year. So its popularity is increasing. It's been used by researchers from over 80 countries, including those from UCL, King's College in London, the University of Edinburgh, and so it's a nice broad reach that the framework is getting. And it's important, though, to remember that this is a theoretical framework rather than a theory itself. It does not propose testable relationships between elements. It just kind of helps you decide what those elements might be. And then it's up to you to kind of go the next step after that. So just a little bit of an overview of a few studies that have used the TDF. So it's been looked at in professional teamwork in operating theatre, looking at barriers to physical activity in pregnant women, influencing vaccinations in the States, and also training skills in train the trainer models to ensure that knowledge gets put into practice. So now we're going to dive into what makes up the theoretical domains framework and what are those 14 determinants that it comprises. The first one is knowledge, and I'm just going to go through the cut and dry definition of each of these before we get to their application. So, and the awareness of the existence of something, the basic definition. The second one is skills, so an ability or proficiency acquired through practice, and these can be physical skills or more emotional or psychological skills as well. Your social and professional role and identity, which is defined as a coherent set of behaviours and personal qualities that you inhibit in your either social or work setting, and it would be different between the two. Your beliefs about your capabilities, so your acceptance of the truth, reality, or validity about an ability, talent, or facility that you could put to a constructive use. Your optimism about a particular behaviour, so your confidence that things will happen for the best or that your goals will be attained. Your beliefs about the consequences of a behaviour, so the outcomes of kind of exhibiting a behaviour in a given situation, and these could be positive or negative. The reinforcement that the behaviour provides you, so the probability of a response between the rewards that you get or the outcome of the behavior and the rewards that it gives you. Your intentions, so your conscious decision to perform a behavior or to resolve to act in a certain way. And these are similarly related to the goals that you might have. So these are a little bit more concrete mental representations of outcomes or end states that you as an individual want to achieve. Something called your memory, attention, and decision processes. So your ability to retain information, to focus selectively on aspects of the environment, and to choose between two or more alternatives. And a more concrete example of this might be kind of decision fatigue, when you have too many options available and you find it hard to pick between them. That it would be fit into this category of the TDF. This is a really big one, your environmental context and the resources that are available to you. So any circumstance of your situation that either discourages or encourages you to develop all the other determinants of behaviour and kind of gives you the opportunity to exhibit a particular behaviour. Your social influences, so all of the interpersonal processes that are around you, really common in healthcare because we work in teams. So the social interactions within a team will influence how the team behaves. Emotions, so by definition are complex reaction patterns, kind of involving many elements which you attempt to process a behaviour or a matter or an event. And finally, the way that your behaviour is regulated. So this is really broad and covers anything aimed at managing or objectively changing actions that you can observe or measure. So that was kind of the theoretical summary of the TDF. And these 14 determinants can kind of inform what are the barriers to a particular behaviour and what are the enablers to a particular behaviour by breaking down how people are acting into these categories. Now, as I mentioned before, the theoretical domains framework is not kind of doesn't look at the relationships between elements, but what's the nice thing about it is that it has been mapped to a thing called the COM-B model and the behaviour change wheel. And these things do give a little bit more of an idea on how exactly people's behaviour is being influenced by combining different determinants of behaviour. So now first a background to the COM-B. Similar to the TDF, we're going to first look at why it was developed. So it was developed because to design behaviour change interventions, we need to choose strategies that will have the greatest effect, particularly in healthcare, we're often limited in our resources, so we really need to target the things that we do appropriately. So the ideal way for us to do this is to base the strategies that we choose on established behavioural theories. However, there's a few issues with some behavioural research in that interventions commonly don't fully analyse the target behaviour before they try to intervene on it. They often don't use theories to predict mechanisms of action. They're often based on implicit or common sense models of behaviour, and this is through no fault of their own. I think it's just a pragmatic response to not having the time and kind of having to pick the best action that seems logically good. And a lot of them use one or two theories that don't cover the entire range of possible influences on behaviour. So all of these factors were recognised in 2011 by Susan Michie and her colleagues, who designed the COM-B. Now, the COM-B stands for capability, opportunity, motivation, and how these interact with a certain behaviour. It was developed via a systemic search of electronic databases and consultation with behaviour change experts. And the search and consultations aim to identify frameworks of behaviour change interventions. And then these frameworks were judged against a criteria of comprehensiveness, coherence, and a clear link to an overarching model of behaviour. So this is the resultant COM-B model, and the black arrows on screen kind of show the interactions between its facets. So you can see that your capability and your opportunity can influence your motivation, and that there's kind of a bidirectional influence between all three elements and the target behavior itself, in that it's kind of like a positive feedback loop. If you're doing a behavior, you're getting reinforcement and kind of experiencing the behavior, which could increase your opportunity to do the behavior or your skills to exhibit the behavior. So it's really just a back and forth relationship there. So if we look at the individual components, your capability can be thought of as your psychological capability to engage in the necessary thought processes to complete a behavior, or your physical capability to complete a behavior. So whether you have the skills necessary to actually complete it. Next, looking at your opportunity, so your physical opportunity afforded from the environment around you, but also your social opportunity from the culture that surrounds you and the social norms that surround you. And finally, your motivation. So what reflective processes are you using to kind of select the behaviours that you'll exhibit, involving evaluations and plans? And then the more automatic motivation or automatic processes, which are more impulsive and involve a little bit more emotion. And if you think about something slightly left of field in terms of the criminal system, if we want to look at how, if someone has committed a crime, we often look at motive, means, and intent. And that's kind of, in a lot of criminal systems, the way that we prove that someone has done a crime or done a particular behavior that we're looking at. And that's actually kind of what the COM-B is based on. So we're looking at your motivation, your opportunity, and your capability to exhibit a behavior. So this kind of model of behavior is really long-standing, and it's present in lots of different aspects of society. Here, we're just taking it and applying it to behaviors for healthcare practitioners in particular. So then if we look how the COM-B and the TDF map on to each other. So here we've got the COM-B, so capability, opportunity, and motivation, broken down into the two subcomponents each. And then around the edges, we've got the elements of the TDF as they map on to the COM-B. So we'll just go around the wheel looking at them together. So you've got social influences, which quite obviously link to your social opportunity. Got your environmental context and resources, which links to your physical opportunity. Your reflective motivation comprises quite a few of the TDF determinants. So your social and professional role and identity, your beliefs about your capabilities, your optimism towards the behavioural outcome, and your intentions and your goals, and also your beliefs about possible consequences. Whereas your automatic motivation, again, more reactive, is the reinforcement or the rewards that the behaviour provides you, and also the emotions that you might have towards the behaviour. Next, moving to capability. So your psychological capability is made up of your knowledge, your cognitive and interpersonal skills, and then the way that you make decisions, and also your memory and your attention. And finally, looking at your physical capability, which is more your physical skills to exhibit a particular behaviour. So if we start to break a behaviour down first by the TDF components, we can then map it on to the COM-B to kind of see how these factors are interacting and get an image of why people might be behaving in a certain way. And then the nice thing is that once we've identified which aspects of the COM-B are influencing behaviour, there's been a lot of work done in evidence-based strategies to then go and change that behaviour. So if we're looking at capability, physical and psychological, you can see here in the table that to target someone's psychological capability, we might look at education and training, but also enablement and empowerment strategies. To target someone's physical capability, we'd look at training and enablement as well. Looking now more at motivation, so your reflective motivation can be targeted through a number of means, and your automatic motivation through a few more by restructuring your environment, looking at people in the environment as models for behaviour, and again by enablement. And finally, looking at your opportunity, so your physical and social, these things are much more about the environment around you, and also any restrictions that we could place on that environment to kind of encourage a particular behaviour. So now putting it all into practice, that was a very brief summary of the TDF and the COM-B, and I'd like to now put it into context of a case study, a study of how you might actually do it in practice. So improvement in healthcare, we usually use PDSA cycles, or for quality improvement, which are plan, do, study, and act. And the important thing is that when we actually get to doing or implementing a change, we often don't integrate behaviour change theory into these steps. It's often, as I said before, quite pragmatic, which is absolutely understandable. But I think we can really learn a lot from integrating these theories into our PDSA cycles. And it's particularly important as if we're using qualitative research to gather data about our quality improvement or our research interventions, if certain questions are not asked of people, you may not get a good picture of all of the influences on someone's behaviour. And so that's kind of why the TDF is a good tool, in that by designing our research studies with it in mind, designing the questions that we ask people in qualitative investigations, we can make sure that we've covered a lot of different possible determinants of behaviour, so that we can be more confident that we have a really clear picture of what's driving people to act in a certain way in clinical settings, and then change that behaviour eventually. So in terms of designing a data collection to use the TDF and the COM-B, how to get the information you want will depend on a lot of things, as it usually does in research. So convenience, your pragmatism, the sample size that you can actually get or that you do actually want, your research question, and how much you currently know about the problem. For example, interviews might be best when you don't know a lot about the implementation factors in a particular behaviour, and they can provide really rich data. But once you have done a lot of interviews, or you've got some rich qualitative data and you've got a good handle on what might be influencing factors on people's behaviour, you could then maybe look at surveys. Once those behavioural determinants are established, they can provide a quicker way to get at the things that are driving people by kind of designing the survey questions and mapping them to the TDF as one example. Finally, you might consider using structured observations to supplement these forms of data collections, just as a good means of triangulating people's self-reported information.
31.
Sorry, if I could just get you to mute your mic if you're watching along at home. Thank you. So these are just a good way of triangulating people's self-reported information, because as we know, people might report things that aren't necessarily reflective of what they're doing in real life. But regardless of your study or quality improvement activity design, it's important that if the TDF is being used for analysis, then it's also used to inform your data collection. So you're designing your data collection instruments to map to the TDF as well as your data analysis strategies. There are lots of published studies that have used the TDF for interviews and focus groups. And when I'm designing a study, I don't like to reinvent the wheel. I usually just find a few published pieces of work that are similar to my own. They will usually publish their question banks, and I can use them as kind of the inspiration for the questions that I'd like to ask. For example, below are some interview questions from a study that looked at pharmacists' provision of self-care advice for antibiotics, and the associated TDF domains are in brackets after the question. So the first one is, could you tell me a bit about how the general public raise or discuss common infections with you in the pharmacy, which is looking at the environmental context and resources, so what's happening in the pharmacy in this study. The second one is looking at, can you tell me about situations where you decide to not give self-care advice for antibiotic prescription? And you could probe further by asking what makes you decide that this advice isn't required. And this is really looking at someone's memory, attention, but more pointedly their decision-making processes. So how are they deciding to give self-care advice? And finally, another example is, what kind of attitudes have you encountered when giving self-care advice, and how satisfied are patients with the advice that you give them? And this is really looking at the social influences, because we know that sometimes we don't like to rock the boat, and if we're encountering lots of negative attitudes in our social settings, we might be disincentivized to exhibit a particular behaviour. Looking now more at surveys, there are a few validated questionnaires based on the TDF. Most are specific to certain behaviours, but there is one generic one. And this is just a screen grab of the study in which the questionnaire is, for anyone who'd like to go and look at that after the presentation. And this is just some examples from this questionnaire for the domain of behavioural regulation. And anything in the square brackets is what you would plug in for your own research question. So the action or the behaviour in a particular context at this particular time with the target is something that I do automatically. And you can get people to rate it from a scale of 1 to 10, 0 being disagree, and 10 being completely agree, or other forms of Likert scales that you might like to use. And by asking people survey questions in all aspects of the TDF, like these in specific to behavioural regulation, you can get an idea of the determinants which are more strongly influencing behaviour in a certain area, particularly by using sliding scales. You can see which ones have the strongest influence. So now for the final bit of the presentation, I'd like to look at a case study of where we've used the TDF and the COM-B to look at a particular behaviour. And this was really done with a lot of colleagues, but largely with Dr. Karen Hutchinson, who has put a lot of effort into this project, looking at the implementation, evaluation of a motor neuron disease multidisciplinary clinic to inform connected and improve connected care. This study was conducted on the Central Coast of New South Wales in Australia. And just to give an overview for those who might be interstate, it's quite a large area, quite a green area, and there's lots of national park and settlements, small suburbs around the national park. It has a population of approximately 350,000 people, quite a large area of 1,600 square kilometres. And Sydney is around 80 kilometres to the south. And just a little background on motor neuron disease as well, which is a rare progressive neurodegenerative disorder with no known cure, and it leads to significant disability and ultimately death on average within 3 years. So the key for people who are diagnosed with MND is to get them access to services as quickly as possible, so we can make sure that their last years or months are as good as quality of life as we can possibly provide. This is complicated by the fact that MND progression is highly variable between individuals and different types. So one person's experience will not be the same as someone else, regardless of if their diagnosis is technically the same. And people living with MND and their families need access to timely and specialised person-centred care and support from their diagnosis to their end of life, as I said, to make sure that this time is as functional and as happy as we can possibly make it. So our study aimed to look at a multidisciplinary clinic for people with MND in a regional area, so in the Central Coast. And we aim to implement this clinic to support connected care across health, disability and aged care sectors, and also to evaluate the barriers and enablers to clinician and participant engagement with the clinic and to the sustainability of the clinic. So the behaviour that we were looking at here, just to bring it back to the TDF, is engagement with the clinic, attending the clinic, and ongoing attendance at the clinic effectively. This is a slide that Dr. Karen Hutchinson has created, which I think is a wonderful way to look at just how complicated the system is for people with MND. You can see that they're in the centre, and around them is all the different types of care that they might have to access. On the left, there's the more tertiary hospital and specialist MDTs, which requires travel and accommodation for people living with MND. Moving more to the centre of the picture, there's local hospitals and teams, GPs and a neurology team who might be working with them. Also community groups, support workers, nursing staff, all of allied health who can support people living with MND. And it's complicated by the fact that depending on the age that you're diagnosed with MND, you will either be kind of managed through the NDIS or through My Aged Care, which have different kind of system designs and different supports that are available to people through them. So what we really wanted to do with this multidisciplinary clinic was bring specialist care closer to home and kind of unite all of these, as many of these different services as we could, so people could get them in more of a one-stop shop. Our methods were a qualitative study, and we conducted semi-structured interviews with clinic staff and also its attendees to get a really kind of holistic view of the clinic. We had 6 healthcare professionals, 2 social care professionals, 4 people living with MND and 2 of their family carers. And we did a semi-deductive analysis using the theoretical domains framework and the COM-B model. And here is just a snapshot of our results. There was quite a number of behavioural determinants that we found, but I'll just be going over a couple of the key ones today. So a primary barrier that we found was a lack of knowledge about clinic structure. And this was because the clinic was set up kind of on the fly it was a really great idea and put together by a wonderful neurologist, but it meant that there wasn't kind of the structures in place to explain, for example, the organizational map of the clinic or how the clinic was structured in its actual instance when it occurred. So that maps to the TDF domain of knowledge and the COM-B of psychological capability. And so if we think back to possible ways that we could intervene to overcome this barrier, we'd look at providing education and training and resources. And ways that this could manifest might be a formal induction to the clinic and some clinic process manuals so that people will have the resources available to understand how the clinic works. A second barrier that we found was poor communication networks and quite a siloed health system, particularly between the NDIS and the aged care system, but also the private and the public sector. But interestingly, an enabler was strong clinician understanding of these silos and gaps and how they could kind of get around them with workarounds. So these things map to first in the environmental context and resources in relation to the TDF, and then to people's knowledge as well, which if we go then to the COM-B is looking at someone's physical opportunity, but then also their psychological capability. So what we found here is that people's physical opportunity was limited, but then they were using their psychological capability to get around that and to make the care work for people with MND. However, if we wanted to stop using so many workarounds and start kind of helping people to officially kind of overcome the silos in the health system, we'd really look at environmental restructuring and enablement. So ways that we could specifically do this would be creating a formal case conference and clinic communication forms in consultation with the MND team and distributing those throughout kind of the healthcare network so everyone understands what's going on at the clinic. And then potentially creating an address book of all clinicians in a particular area that are assigned to a clinic participant so everyone knows who they need to contact if they need to contact someone. A third key barrier was the cognitive overload of clinic planning and administration, in that the clinic was kind of happening privately outside of a lot of people's day jobs. But a key enabler was that there was a dedicated administration staff on site. There was a current clinic reminder system and lots of written reminders and checklists. So even though there was a barrier in people's memory, attention, and decision processes, which then maps to their psychological capability, the environmental context and people's physical opportunity was kind of helping people overcome that barrier. So if we wanted to intervene further and further help people to overcome this barrier, we would look at environmental restructuring and also some education and training. Some specific ways to do this for our clinic might be creating pre- and post-clinic checklists, incorporating current reminders and systems into the checklists, and training administration staff in all of the clinic checklists. So we just weren't handing them something and expecting them to do it without any help. And one final barrier that we found was strongly defined scopes of practice and a related reluctance to cross into other scopes. And that maps to people's professional role and identity and their reflective motivation. And this has come up in all studies I've done using the TDF, in that we're kind of taught how we need to act as healthcare professionals for safety reasons. But that means that if there's overlap between our scope and someone else's scope of practice, it can sometimes be difficult to decide who's going to do what. And people sometimes need a bit of a helping hand to either step into what they perceive as another scope safely, or to kind of step back and let another profession do something which is indeed in their scope as well. So a way that we might kind of overcome this barrier would be environmental restructuring again, but also some persuasion. And a specific way might be a team discussion about what is safe crossover between clinical scopes with scenarios, so that people kind of have an example of how they might behave if they kind of felt that they were going into someone else's scope of practice and they weren't sure whether it was appropriate for them to do so. This one was quite key to a multidisciplinary clinic, because the definition of the clinic is you all work together. And also at some times, not all professions were available in the clinic. So people sometimes needed to step up safely and within still their scopes into things that maybe they traditionally perceived as someone else's job. So in conclusion, implementing any intervention into a complex system will become with unique barriers and enablers. And if we can first map the system and understand how things fit together, then that can help us get a picture of what's going on. But a formal and theory-grounded assessment of factors can complement system mapping to overcome barriers and leverage available facilitators in the most effective way possible, to kind of encourage behaviours that we'd like to improve healthcare for our target populations. So I'll open it up for discussion now, but I'll just pop this acknowledgement slide up to everyone who's contributed work to the presentation that I gave today, and particularly to the MND study team. And that's my details there. So I will make sure I can hear everyone, and then, yeah, open the floor to any questions. So Mila, did you have your hand up?
Yes, thank you for this wonderful presentation. I've enjoyed it, and well done through persevering through all the troubleshooting with the technology. It's not easy when you're the one presenting. So just wanted to acknowledge that. A bit of a practical question towards your example that you've presented on, were you able to apply any of the recommended changes to that clinic, or was the purpose of the study just to explore what the barriers were? Like, I guess I'm asking what the impact was of that. And a second to that is perhaps a Karen question is, what did she use to draw this wonderful map of all the interactions? If there's a specific software or something that we should know about, please do share. Thank you very much.
Thank you. It's a great question. I'll answer the first bit and then I might throw to Karen for the second. So our intention for the study was just to map the barriers and enablers as the clinic was in its first iteration. And now it's moving into its second. We're going to use the findings to hopefully implement some of those strategies that I outlined, but we're really conscious of co-designing it. So we wanted to take these results back to the team and back to the people living with MND to make sure that it really did match what they needed, and then pick the ones that we were going to implement. So watch this space. Hopefully in about a year's time, I'll have some more findings for you.
Thank you, because that's a very common issue that having spent a long time within the healthcare system, there's a lot of great ideas, but the implementation of something, or just a lot of them seem to be very basic logical things, you know, like provide an organizational map or instructions, orientation manuals. They seem to have been missed in that desire to help people.
Absolutely, yeah. And when we might find that the simple things themselves, they don't work, and we need to go for something more complex. But yeah, that'll be the next part of the journey. Karen, did you want to speak to how you made that wonderful map?
Yes, hi. Sorry, I'm at the clinic at the moment, so I do need to head off. But thank you, Georgia. That's a great presentation, and it was great to see all your amazing slides. And yes, it was just PowerPoint that I used to do that map, Mila. So yeah, it's quite a good tool when you actually pull that all together. And it just, I think sometimes visual representations really highlight some complexity that maybe is hard to, you know, write succinctly. And yeah, the complexity really hits home with that diagram. So thank you. And thanks again. I'll have to pop off now, but appreciate it. Thank you, Georgia. Thank you.
Georgia, I don't know if you've seen there's a question in the chat from Astrid. Thank you so much for your presentation, really comprehensive. I wonder if you could give a little bit more detail about how you undertook the analysis.
Thank you. Okay, I'll just repeat the question for the people in the room. So are you able to offer a bit more detail as to how you performed the semi-deductive analysis? Yes, so what Karen and I did was we first coded all of the interview transcripts to the elements of the TDF, but we left a category for other, because I always find there's a chance that something will come up that doesn't fit into the framework. And we also wanted to do, we wanted to look at the effects of the clinic, which might not have come out via our TDF analysis. So the way that we probably did it a little bit differently in ourselves, but the way that I do it is I will have one TDF component in mind, for example, knowledge, and I'll go through all of my qual data looking for quotes that map to knowledge, and then code that using, we just used Excel, but I've done it before with NVivo as well. And then going through continually with all of the TDF components. And then Karen and I came together to compare what we had pulled out for each component of the TDF and aligned ourselves and through discussion effectively, and then looked at what we'd coded into that other category to see if there's, you know, little bits of the data that we might not have captured with the framework analysis. Does that answer your question, Astrid, or would you like, is there any follow-up question as well?
I was going to pop it in the chat, but I might just pop myself off mute. Thank you so much. That's really, yes, that answered my question. So just to clarify, you were open to the potential that there were themes or constructs that may have emerged that weren't part of the TDF, and then and so therefore kind of created an additional construct as required.
Yeah, I think the research question that Karen completed the interviews and then came to me for help with the analysis, and her questions were quite broad in that she wanted to know about the barriers and enablers, but she was also really interested in the unintended consequences of the clinic that it might have brought about. So we felt that we wanted to make sure we didn't lose that data, and how that the consequences may have interacted with, especially the beliefs about consequences bit of the TDF, to really make sure we pulled that out. So I think there is, depending on your research question, there is some wiggle room, provided that you do stick to the framework, but then, taking a broader look at the data as well to supplement what the framework tells you.
Yeah, great. Thank you so much.
Alan, do you have a question?
Yeah, I do. Can you hear me okay?
Yeah.
Yeah, oh, fantastic. Great presentation. I really found it really good and neat how you plan through using the TDF to analyze your data and guide your survey, kind of the questions that you're going to ask them, and those steps. That I think that makes for really good, compelling, papers and planning and all of that. I was just going to ask about the next steps, because I think Karen hinted that, this is not funded and it's, running a lot on people's kind of generosity. We do a lot of these kind of things in medicine because they're a good idea and they seem to work. How are you going to use are you going to use the TDF for the evaluation part and answering the kind of questions that funders need, like, cost, sustainability, effectiveness, adoption, all those kind of things? Or are you going to use a different framework for that?
Great question. So our aim with the TDF was to analyze this data, to take to the funders to show the difficulty of doing this, and the fact that we would need more resources, which it has successfully done. And I think it was a really great justification. But as you suggest, we would look at the other implementation factors in a more formal analysis, and would be broadening out to probably more of a systems level framework to do that part of the investigation. I think what we really wanted to do was look at practical solutions at the clinician level here to help the clinic run better, but also to show what these clinicians are facing, because as you say, things that are great ideas in healthcare often face a lot of things, and it's individuals who persevere through it. We will be certainly, looking at the things that you said in terms of particularly cost and effectiveness in other ways when we do the full clinic evaluation. Yes. Okay. Thank you for everyone commenting in the chat. Is there any other questions at the minute?
Any questions in the room?
No. Oh, Seamus?
Thanks, Georgia. Thanks for a great presentation. Just following up from the last question, I'm a sociologist by background, although I was originally a physiotherapist and worked in healthcare for a while. And I thought it was really interesting the way you suggested you may move on to sort of a systems level analysis for that next phase or stage. And I was just wondering if you had any comments or thoughts on how something like the TDF, how it might best be used to try and make sure we can capture some of those more systems level or environmental influences upon individual behaviours and the sort of things that people might talk about or raise when interviewed. Would you have any tips for how some of those more system level, or macro level factors or meso level factors might be influencing those individual level responses, and how we might capture that?
Yeah, great question. I think there's a few ways you could do it, and they probably depend on the resources that you've got available. I do think that the TDF construct of environmental context and resources really does give you the scope to look at what's surrounding a person. And so maybe focusing on that data in particular, if you were really interested in the systems level, and then applying a systems thinking lens to the information that you got about someone's environment, so that you're not, you know, doing two analyses, and, you know, that's a lot like resource intensive, but putting your focus, if you were really interested in systems level one there. And then I know there's a number of complexity frameworks or systems level implementation frameworks that probably just could be used if you didn't want to use them formally, just to guide your thinking about those factors. So you're still operating within the TDF, but broadening it out to make sure, as you said, that you don't you don't miss those things. The more resource intensive one would be to do that full systems map with like systems dynamic modeling, and if you had the resources to do that. But yeah, it really would depend.
I'm not good at maths enough to do that.
Yeah, I feel the same. But yeah, I mean, that's a good point. And I think the systems dynamic stuff would be really wonderful to be able to bring to our research, but a lot of us aren't trained in that from the beginning, and it would be really cool to be able to integrate those two fields, I think, particularly from a complexity perspective, because that's what healthcare is a complex system.
Great, thank you.
Any other questions? So if not, we might wrap it up there. Just making sure I haven't missed anything in the chat. Oh, all right. Well, thank you everyone for coming. Apologies again for the tech issues. And hopefully we'll have fixed them by next time. And we look forward to seeing you all at next month's group meeting, and we'll be sending out details of that shortly. And feel free to contact me via email if there's any follow-up questions that I didn't cover today. Thanks again.
Thanks, Georgia.